we're going to change gears now, and we're going to talk about disclosing events. And I'm going to lean heavily on my partner in crime, Dr. Whitman here, who's going to be helping with this session. We're going to have some interaction. We're going to have some role playing. And so look around you. You'll be working in groups of 3. All right. So look in your row and just kind of see who the 3 might be. I see a lot of threesomes already kind of in the rows. So I think you'll be able to find 3 of you to work with. All right. So why are we talking about disclosures, adverse event disclosures? 1, because we have to. Our accrediting body says we have to make sure we teach how to disclose adverse events should they happen, when they happen, I should say. And plus, it's part of medical practice. We know adverse events will happen, and we need to be prepared to address those as they develop. They will happen. So when you think about the terminology of what we consider to be adverse events, there's a whole spectrum of events that we could think of. They're just unsafe conditions, right? Parts break, kits that you might be using might have a piece missing. Something might have dropped on the floor and become contaminated. There might be a spill. Yesterday, I was at the hospital rounding on consults, and I walked down the hall, and the nurse says, "Oh, look out. Someone's biliary drain had dribbled all across the hall to the other side." And she was using the hazardous waste disposal system to clean this up, right? I mean, those things happen every day. Near misses, things that could have been pretty serious, or great catches if you like the positive glass half full terminology. Things that could have been adverse events, but we caught them in time. And so writing the wrong order on the wrong patient, writing the wrong medication dose, selecting a medicine that someone might have an allergy or an adverse reaction to. Okay, but medical errors do happen. We live in an imperfect system, in an imperfect world, right? Human bodies are imperfect. They're all unique. You can't always predict that what you do 10 times to someone and it has no problem might not mean the 11th time something happens. And so medical errors are known many times, complications of what we do every day, hopefully with a very, very small rate of them happening. But we do know that they happen, such as wrong site procedures, and again, an order that was ordered on a wrong patient but carried out. So sometimes we can anticipate these, but sometimes we can't. We don't know that someone has an allergy until the first time it happens. We don't know that a surgery might result in more bleeding in one person than another. So there's a broad spectrum, as I mentioned, of adverse outcomes, a frequency at which they happen and the severity of which they happen. So we would hope that we could create a system in healthcare that would have low frequency and low harm, right? We'd love to live in this lower quadrant all the time. And we aspire to that, which is why we have event reporting systems to help us track when systems errors could take place or do take place to try to prevent these from happening again. So we have an event reporting system at our hospitals. Most of you will work at an SSM hospital for some, if not all of your time, but the VA has its own adverse event reporting system. And I trust St. Elizabeth's has its own as well. Mercy has its own. So on the main pages or through Epic, if you're logged into Epic at an SSM or Mercy hospital, there's going to be a tab where you'll see event reporting. Okay. And when you click on that, you go into a system that actually collects information. You can usually do this anonymously if you want. If you place an anonymous event report, you'll never get any feedback or information on how that was resolved. But you can certainly do it anonymously. And not everyone who was involved has to put in a report. Hopefully someone will put in a report. But putting in and knowing how to do an event report is actually something that ACGM expects all of us in healthcare to do when it happens, and to us be able to get feedback on these reports and how they're resolved and how we can hopefully reduce or eliminate those in the future. So what do you do if an adverse event occurs? Let's hear some thoughts. Most of you probably have had something witnessed or been on a team or in part of a patient care situation where an adverse event happened. Take care of the patient, right? First things first. Sometimes these things are urgent, critical, or evolving, and the first and foremost is always take care of the patient. Inform your supervisor, if that's your senior resident, your chief, your attending, probably will know sooner than later if they're not present when it happens. But we do need to report these through the hospital risk management system, make sure that there's a plan of care developed for how we will address that, determine what other medical teams or providers might need to be involved. And we need to disclose this back to the patient to whom it happened, because not all events that happen are known to the patient and family, right? Sometimes when procedures are done, pieces of catheters might be dislodged and end up in someone's part that they shouldn't be. They may not know that, or they may have a significant symptom develop immediately. So we need to take care of the patient and the situation and report it, and then make sure we've disclosed and just documented and discussed what are the next steps. Because disclosure is really a communication tool, and it's a communication skill. And like other skills, we don't always know how to do them comfortably or easily, but we can learn how to do them more systematically so that they become a little bit easier and more comfortable. So I'm going to use the analogy of bad news for talking about adverse event disclosure, because most of the time, an adverse event is bad news. And for those of you who have been involved in breaking bad news conversations, there's a way that can be used to roll this out with yourself, your patient, your team, to try and remember and to cover all the areas that hopefully can make that process as calm or easier as possible. So who's heard of the spikes mnemonic? Look, a few. Okay. We tend to like mnemonics, right? They help us remember things if we can keep the letters in mind and follow a stepwise process. So this was published back in 2000 by an oncology group, because you can imagine, right? Oncology, kind of a lot of bad news in oncology that they have to deliver, right? And they said, how can we do this in a way that makes sure we cover all the bases? So for spikes, for S, is setting up the interview, setting up the approach, all right? Right facts, right time with the right people involved. What's the patient's perception? What do they know? What do they don't know? All right. I's invitation. Are we, the patient, the family, available? Is the rest of the medical team available and ready to have this conversation and have the right information available to discuss the event? Then there's the delivery of knowledge, responding and acknowledging any emotions that might develop, and then summary and strategy and where are we going for next steps. Okay, so Dr. Whitman and I are going to work on this together. I have my script somewhere here. So we're going to have Rosie and Alex start passing out the envelopes. Do not open them yet, but there should be one envelope for every group of 3. Okay. The envelope should say number 1 on it. We have 2 scenarios. The first one we'll do is number 1. All right. So Dr. Whitman and I are going to be giving you an example of a breaking bad news. All right. I'm going to be the physician. Dr. Whitman is the patient, and I'll let you observe, and then you'll give us some feedback and reflection on how we did this. Hi, Dr. Whitman. Glad you came in today. I wanted to talk about that skin biopsy you had done last week. My nurse said you've been calling a lot lately.
I'm really anxious to know the results because we're leaving next week for a vacation in Mexico, and it would really be great to celebrate good news.
I'm sure you'd love to hear that. Your disease is metastatic, so we're trying to find out what that spot is on your arm and if it's cancer. Unfortunately, I can't give you any answers today because the sample was non-diagnostic. There was some sort of problem in the lab and the tissue couldn't get run right. And so we're just going to have to do another biopsy.
Well, I don't understand. Can't we just send it to another lab?
I'm not really sure what happened. I'll have to get in touch with the lab, but it's easier just to get another test and a biopsy. I'll have a desk book you next week to come in and do that for us.
My oncologist was kind of hoping to start my treatment by the end of the month based on the results.
Well, unfortunately, this happens a lot with the laboratory. I'm sure your oncologist will understand. We'll just get another biopsy. It's not a big deal. My schedule is pretty open this next week, and I'm sorry I don't have any good news to give you for your vacation, but I hope you can still have a good trip. We'll see you in a few weeks.
Okay. Easy for her to say, right?
All right. So let's rewind and let's see if we can have a different conversation. Hi, Dr. Whitman. Thanks for coming in to talk today. I wanted to go over your biopsy results with you. I know that there were some complicating factors, so it's better for us to discuss this in person. Are you comfortable? I know that you've had some troubles with that wound and the dressing.
Yeah, the pain's mostly gone now. Is there something wrong? Did they find a cancer? I'm going to leave for Mexico next week for vacation. It would really be wonderful to have good news to celebrate.
I'm really glad you're feeling well enough to take that vacation. You mentioned cancer, so it would help me to understand what you know already about the cancer and the biopsy. Are you willing to talk about that today?
Sure. So I've had cancer for a couple of years, and then it spread to my lung. So we've been doing the chemotherapy for both the original cancer and what's in my lung. And then when the lump came up on my arm, my oncologist wanted to have a biopsy because if it's another cancer, he wants to add some chemo to the protocol. So that's why I thought it'd be better to take my vacation now if I'm going to have to go through more of this.
I can see why getting that biopsy information right now is important for you. So when I did the biopsy of the lump on your arm, the laboratory found out that the tissue in the sample was pretty damaged. We call that necrotic. There wasn't enough healthy tissue in the sample to run all the tests we ordered. When the lab tried to complete the final test, the remaining tissue was not able to be used for the test. That's why we might need to get another biopsy of the skin.
I really don't want to have to cancel my vacation just to do another biopsy. Can't we send it to another laboratory?
Unfortunately, another laboratory will have some of the same difficulty because there's not enough of healthy tissue in the sample to run those tests. I know this is disappointing news. Would you like me to call your oncologist to discuss the situation? Perhaps we can come up with another approach. In the meantime, I'd be happy to schedule another biopsy for you after you come back from vacation.
Yeah, I'd appreciate it if you talked to my oncologist. And I think going ahead and getting the biopsy scheduled is a good idea, just in case we need to do it.
I'm sorry this isn't the good news that you were hoping to have as you go on your vacation, but I hope you can still have a good trip, and we'll see you in a few weeks.
Okay.
All right, so who wants to reflect on discussion number 1? What was good or not so good about discussion number 1? Thinking about our spikes. So I didn't acknowledge her. I stood over her, used a lot of medical jargon. Yeah, I just jumped right into it. I had an agenda to get to the bottom of that discussion, didn't I? What else? Back. Yeah, so it's nice when you can get the facts together before you walk in the room to have those facts, or to have the facts of what other teams have already revealed before you walk in, and having that is part of the preparation for that discussion when you can and when the time will allow you to do that. Whose concerns was the physician focused on? Not particularly patient-centered. So in contrast, what about the second discussion? What was different about that? More empathy. So more information planned and brought forward to the discussion. Okay, getting what the patient knows out in front. I will tell you that that's probably my most important lesson learned over time is understanding what the patient already knows. I can't tell you how many times I've walked into the room thinking I had to reveal, disclose, or cover something to find out 5 other teams have already been there and already had that discussion. And sometimes the patient's tired of talking about it and they don't want to talk about it again, or they've gotten 5 different versions of what happened, right? So having an idea of what the patient knows is really an important starting point. Or your conversation can sometimes head off in a wrong direction pretty quickly. All right, anything else that you saw that was useful or not useful? So hearing what the patient's priorities and importance are of things, even if we think this is an emergency, it may not be in someone else's life an emergency or an urgency even to get these things done. So meeting with the patient where they're at with their plans and their needs. So good. Thanks. All right. So that was our inconclusive biopsy specimen. All right. So how about let's just talk briefly about I'm sorry. Who here has been in a conversation with a team or yourselves with another patient or other provider where I'm sorry came out? All right. We're kind of scared a lot of times to say I'm sorry. Why? We're afraid that's going to indicate blame. But it's important to show our empathy and regret for the situations that we find ourselves in with our patients in. All right. And there's ways to say it that don't suggest fault or liability or that there was negligence, but to understand that they and you are not in a situation that either of you felt you would be in or wanted to be in. We're really sorry you're going through this. I'm sorry that this has happened. I apologize for the difficulty that this is causing you or that you're experiencing. We regret that this happened and we don't want this to happen again. And we want to help to figure that out so we can make the changes we need for your care and others. Okay. What you don't want to do is show that you don't feel empathy, that you are deflecting or wanting to turn that to someone else. Oh, it was the laboratory's fault that the sample was bad. If only the nurse did this, if that team hadn't done that, he didn't order the right thing. None of those are very productive pieces of conversation. I'm sorry that this is happening right now is a often neutral and but an empathetic way of acknowledging that we're in something that is unwanted. All right, so we're going to do role play number 1. You have hopefully in your hands among 3 of you an envelope with a patient, a medical provider, physician, and an observer. So the observer is going to look at the spikes elements. The patient will be the patient role. The physician will be the physician role. Don't share those with each other. No cheating. And we'll give you a couple minutes to go through that scenario with your threesome, and the observer should be making notes of how spikes is used in the conversation. Okay, so let's regroup. Let's hear how this went. All right. It's Friday. It's Friday afternoon. Nothing good happens on Friday afternoon, right? It's a race to the finish to see what you can get done before the day closes. And your poor patient's been waiting for endoscopy all day. No food, no water. And at 3:00, endoscopy says, oh, we got to cancel. We had abnormal labs. You have to wait till Monday, right? Because no elective endoscopy is usually done on the weekend. Patient was supposed to go home Saturday. Patient's upset. All right. So what happened from the physician's perspective? So that 3:00 lab that was hopefully going to be back actually was available earlier in the morning, but unfortunately no one on the team noticed. And so platelets were low, could have maybe gotten a transfusion, but now it's too late to get that done before endoscopy closes. So now you have to go in and talk to the patient. All right. Is this bad news? For so many ways for the team, right? And the patient. Is this an adverse event? No. Maybe on the, did it cause actual harm? Well, psychological harm, emotional harm. The patient was supposed to go home. That financial harm, right? They got to stay in the hospital now for a couple extra days. They'll get poked every morning again, more blood draws. I mean, this just wasn't what we wanted or expected to happen, right? All right. So let's hear from the groups, the observers. So what did you see and observe of the spikes in your group's discussion? Yes. Okay, good. Because patients don't always understand all the necessary labs and tests and things that have to happen in sequence. So just making sure that the patient even understands the whole reason behind why this test was important. Okay. Other groups. What did you, someone up there, observe? Okay, strategy for going forward. So that's the next or last step, right? What are we going to do next? What can we not? Can't do everything maybe you want to, but at least come up with some of your strategies. I'm going to ask Alex and Rosie to pass out number 2 while we're talking. Did anyone say I'm sorry? Do you hear any I'm sorries? All right, some brave people out there. I'm sorry. I'm sorry this happened. Yes, tell us. Thank you. So showed empathy, said was sorry, had a strategy to how to move forward. All right. So the patient felt satisfied. Patients, we all want to be heard, right? I mean, when we get grumpy and angry, sometimes we don't need someone to solve the problem, but we just need someone to listen, right? Or to be the receiving end of venting. Unfortunately, that's part of what we do in a service job, right? We're in a service job. And we have to hear all sorts of things, some of which are under our control and some are not. But being a listening ear is often just what people really need to feel like that they've actually been heard. Other observers. And here's the secret for you guys. When the attending walks in, sometimes they aren't the ones that get the blowback, right? Because by that time, many others have been in and probably they've already had their chance to vent. So sorry. The first people that tend to be in the room are the ones that often bear the brunt. So, but you know, sometimes people want to hold it in until they get to the attending too. But just know, sometimes people just need to have that chance to vent. Other observations? All right, so we're going to do one more. All right, so switch it up. If you're a patient, do something else. If you're the physician, do something else. All right, and we're going to give you another 5 minutes. Scenario number 2, and then we'll talk about that one. Okay, so let's talk about situation number 2. All right. So in the landscape of adverse events, right? Would you say this is a frequent occurrence? Yeah, pretty frequent, right? It's 11 o'clock, phlebotomy comes to the room. They had already come by once today, and you were a difficult stick. You got stuck a lot of times. You're done with it. All right. And you don't want to be stuck again. So the nurse comes to find the physician, say, what, will you go talk to the patient? Physician, their situation. Patients refused the blood draw. They had their morning labs, but they're going for a procedure. And oops, there was something we forgot to order that needs to be done. All right, well, we'll just reorder it, right? Well, and that now puts us in the situation that we're in right now. So again, in the scheme of adverse events, right? This isn't wrong side surgery, amputation of wrong body part, right? But this is event reporting. You have to talk to the patient and disclose this. So we all have the ability to and the need to be able to disclose these, you know, maybe micro adverse events, but you know, you're not going to probably be the ones, at least not right now, to disclose major, significant, serious types of adverse events that may happen. But these are the things that are going to happen every day that you will be the first line to actually discuss with your patients. And so having this opportunity to think about this mnemonic to kind of frame that for you, I think will be a helpful starting point. All right, so let's hear from the observer again. What did you see or hear in your group conversation that was useful, interesting about the conversation? Yes. Right. How did the patient respond to that? Mm-hmm. Yeah. So you can't always make things right, but you may be able to, again, acknowledge and de-escalate a situation. Doesn't mean people aren't still going to be mad. Doesn't mean they're going to have to be stuck again, maybe, but at least it may step that level down a notch. Yes. Okay, so talking about what can we do? This is the strategy part going forward, right? Is there anything we can do to make this next draw better, right? If you're in the kids' hospital, you might put some lidocaine on the area to make the stick easier, right? Maybe some other solutions, ideas. Good. Other groups? Things that you saw? How many I'm sorries were in this discussion? All right, a few more I'm sorries. Okay, good. All right. Any other reflections? Any personal stories? Any things that you saw done particularly well or not so good in previous team experiences that you want to share? Might be helpful. We learn as much from what we see that we don't want to do as what we see that we do want to do, right? Nothing like seeing like something you're like, oh boy, I'm never going to do it that way, right? So you take in all of that. Hopefully, though, we see more positive examples than negative examples. All right, so hopefully you had a few good takeaway points and a few things that you can put in your armamentarium for the first day, the second day, and onward.